All right, thank you so much for having me here to present these results. I have no financial disclosures. I am PI of the COVID-out trial that was discussed yesterday, and I will be talking about off-label use of FDA-approved medications. And I'm funded by a Career Development Award, and the funding for the ACTIV-6 trial is mostly from NCATS. All right, so the rationale for studying metformin. Early, in 2020, 2021, there were a number of observational studies published. Each of these has its own limitations. These are all prevalent use studies, so individuals with metformin use who then got infected, and then their outcomes from the infection. But so while they each have limitations, there was a growing body of evidence. All these point estimates are on the left side of one, suggesting a protective effect from metformin. On the right, you can see a study done in individuals without diabetes, so more similar to the sample of individuals eligible for clinical trial. And then Usman is a prospective cohort. So building evidence, and then in 2022, we published the acute outcomes from the COVID-out trial. So the primary outcome was severe COVID by day 14. We defined severe COVID as one low reading on a home oximeter, ER visit, hospitalization, or death. As Dr. Folks pointed out yesterday, when you have an outcome that's overly sensitive, there's a lot of random noise. Many people are classified as having that outcome that might not actually have the disease of interest. So the primary outcome was not significant, but you can see pre-specified secondary outcomes below that, and then the same outcomes at day 28 as opposed to day 14. And we did enroll pregnant women, or pregnant individuals in the trial. ACTIV-6 allowed pregnant individuals to enroll, but I think there were none in the ACTIV-6 trial. All right, so then about 10 months later, the long COVID result from COVID-out was published. This was the question: has a medical provider told you that you have long COVID? Yes, no. And then if they said yes, more questions popped up, and then we obtained those medical records to confirm. And so you can see the point estimate of 0.59 that was discussed yesterday briefly, and then those same a priori subgroups, and then our viral load outcome was a paper below that. So this, I think, is the rationale that led the ACTIV-6 leadership to add metformin as the last medication on this platform trial. So ACTIV-6 was a decentralized, nationwide platform trial. They tested a number of different outpatient therapies for treating acute infection, and metformin was the last medication on this platform. They also expanded the population studied to individuals who hadn't yet been studied in acute outpatient treatment trials. So everyone in their last few medications on the platform were infected after the Omicron variant started, and they allowed individuals with prior infection to enroll. The COVID-out trial excluded those with a known prior infection. And the COVID-out trial had a minimum BMI requirement of 25, so overweight or obesity, but the ACTIV-6 trial did not have that BMI requirement. The other requirements were similar to other trials. So the primary outcome, there was an acute primary outcome during the 28 days after infection, and then the primary outcome for the long disease process was this question on day 180. Please choose the response that best describes the severity of your COVID-19 symptoms today. And then the options were no symptoms, mild, moderate, or severe. And this question was also asked on day 90 and day 120. So this question, or this way of defining long COVID has some limitations. We know that long COVID is not necessarily a daily disease. There's waxing and waning of symptoms, and the symptoms on day 180 could be from a pre-enrollment long COVID. Individuals who deceased were also counted as having the primary outcome, but there were no deaths in the trial. So pre-specified secondary outcome was the same outcome as the COVID out trial. Have you been told by a medical provider that you have long COVID since your last survey? So the since your last survey helped us make sure we were capturing new cases of long COVID. This question was asked on day 120 and day 180. So the day 180 date is what closely mirrors the COVID out trial. And then the dosing in active 6 was the same dosing as in the COVID out trial, 500 milligram tablets of immediate release metformin with a small dose titration on day 2 and day 6. The analysis for active 6 was Bayesian, and there's statisticians in the room that can correct me, but so prior distributions can inform Bayesian analyses. However, in active 6, they use non-informative prior distributions, so as if there were no prior research. And then a posterior probability of efficacy is similar to a p-value, except for when you're using Bayesian analyses. So a p-value less than 0.05 is what we use to answer one question: can you reject the null hypothesis? A PPE, my understanding is that it gives you a little bit more information. It could inform a conversation. So it's the probability that this intervention lowers your risk of long COVID by 50% is 80%, the PPE. So the threshold for efficacy for a PPE is usually 0.95. It was 0.975 in active 6, just to make it extra hard to reach that efficacy threshold. So the results, it enrolled from September 2023 to May 2024. Most participants in the metformin arm were enrolled during the JN1 variant, which was infective but a pretty low burden variant as far as symptoms and severe disease. The median age was 47, and you can see 54% had a known prior infection. And when you look at known prior infection or any vaccination, 83% of participants had at least one form of prior immunity. So highly relevant population. So the results for the primary outcome were not significant. Posterior probability of efficacy, 0.83. And then the pre-specified outcome that most closely mirrors the COVID out trial, the PPE was 0.96. And you can see these are percentage points. So there's a low incidence of symptoms, 2.9% on day 180 in the metformin arm, 3.6% in the placebo arm. And these are those same results on a relative scale. Primary outcome, pre-specified secondary outcome, and importantly, there were no safety concerns. So no episodes of lactic acidosis, no episodes of healthcare recorded hypoglycemia. 2 individuals in the metformin arm and 4 in the placebo patient-reported hypoglycemia, so less than 0.5%. Okay, so active 6 confirms that starting metformin during acute infection is safe, and it extends this finding from the COVID out randomized trial to those with a normal BMI and to those with a known prior infection. It also confirms the prevention of a clinician diagnosis of long COVID to those with a normal BMI and those with prior infection. So just in the context of emerging data, this paper was just published, and the reason that we chose the diagnosis of long COVID, has a clinician told you have long COVID, is because we wanted something that could be confirmed in the EHR. You know, symptom-based diagnoses couldn't be confirmed in the EHR, and when we were adding the outcome to the COVID out trial, you know, Recover was not quite up and running with all of their symptom assessments. So it's nice to now see other research groups confirming these findings in the EHR. So this study used a sequential target trial emulation analysis, which is an appropriate way to handle not having an active comparator. They did require adults to have a BMI over 25, so this analysis is similar to the COVID out population, and they showed a pretty large effect for preventing post-COVID condition. One more emerging study. This is a new user active comparator analysis, so essentially a target trial emulation in the US, excluding any indication for metformin. And the comparator was, new metformin prescription within 6 days of documented infection, or new prescription of a placebo, ivermectin, fluvoxamine, montelukast, or fluticasone. And the outcome was long COVID or death. And this result is similar to the COVID-out trial and the other target trial emulation I just showed. Okay, to summarize, so we now have 2 large randomized trials. Over 4,000 individuals have been randomized to metformin or exact matching placebo. And both trials have had a confirmatory target trial analysis in very relevant populations to the state of the pandemic today. The primary outcomes for the clinical trials were not significant. However, pre-specified secondary outcomes in clinical trials have a low risk of bias and can be used for making guidelines. There's no requirement that you can only look at the single primary endpoint. And then when 3 of these studies showed a larger effect size with earlier initiation of metformin in subgroups, so sort of a dose response, but these point estimates and confidence intervals are for the entire sample in each of these studies. So you could summarize this by saying that if you repeated these studies over and over again, you would expect a risk ratio or a point estimate anywhere between 0.16 and just under 1. So a risk reduction of anywhere from 84% to 1% would be highly consistent with this data. You'd mostly expect a 50% reduction in the risk of developing long COVID if you start metformin at the time of acute infection. This is a very non-intuitive use of repurposing a medication. Why would a chronic diabetes medication be useful for treating an acute viral infection? But the biguanides were around in the early 1900s, and the earliest papers on them were in the setting of viral infections. And I guess we're just getting to what Osler predicted, that eventually we'll just use 1 or 2 medications for dozens of diseases. So thank you so much. Thanks to the Active 6 team. There's so many to thank, and thanks for having me.